So welcome everybody. I welcome Dr. David Kaufman. He is an infectious disease expert in New Jersey, one of the most renowned physicians. It is my privilege today. He is going to talk to the students about the US medical systems. We are going to arrange a series of such webinars on different topics, because this American medical system, the hospital systems, what it takes to make a great doctor. How about the residency part of it? What is the residency? What is it really looking? How we should create a profile? Now, these things are big topics, and that is why it is not possible that we cover into the one system. So we thought that we will have a series next week. We will publish on our website also the complete schedule part of it. And Dr. Kaufman will be taking various sessions onto that. I welcome Dr. Kaufman. So, sir, today we have the medical students who are already now in the part of the medical system. They have already taken the admissions into medical system, and they want to become a doctor into that. So maybe you can introduce yourself in a brief, and we can you can let me know. We can run the slides part of it. I request all the students to put your questions in a question and answer tab. And once the presentation is over, I will come back. I will read one by one question, and I'll ask with Dr. Kaufman for each and every question. Please start typing into the questions, but most of the questions he will be answering as the presentation goes. So if I feel somewhere the questions is relevant to the topic, I will intervene. Otherwise, we will take positively this session. So in a question and answer tab, please start typing the question. So over to Dr. Kaufman. Welcome, and let's start our first of the series of webinars we'll be taking for Indian students. Thank you.
Well, thank you, Tushar. Good evening to all of you, and good morning to me. We are 9.5 hours apart and 7,500 miles away from one another as I begin this morning. I'm going to start, please, by thanking Dr. Tushar Dioris here for his many years of fine work and for inviting me to speak to you. I am honored to do so, and thank you all very much for attending. I hope you enjoy the presentation of the webinars I will give. This will be what we would call in America the driest of them, not much humor, lots of numbers, and that. So as I say, we're 9.5 hours apart, 7,500 miles away. If I were to come to see you at this time, I would leave one continent, I would fly across 2 oceans, and 2 continents or parts of them to land in a 4th continent. As much of a physical and time journey as this is a cultural journey as well. I've been very fortunate in my life to have many Indian physicians as everything from golf partners to colleagues to practice partners in my own private practice. And I've learned to appreciate at least some of the Indian culture. However, while I'm mindful of the differences in the culture, I'm going to apologize in advance if I put things in a certain way that is offensive to you or difficult to understand. I am not a master of the differences in culture. So on to the subject at hand, and what I'm going to do, having been tasked with this by Dr. Dioris, is I've decided to work backwards. This is something we do a lot in infectious diseases. We have a patient show up, the patient can't tell us very much. They have a fever, they're in septic shock. We don't know what's wrong. We examine them. It's not quite clear. And then the next day, the blood culture becomes positive, and we look at the bacterium, and the bacterium tells us a story. So we start at the end, and that works us back to the beginning. And that's what I'm going to do today. So I'm going to start at the end, and the end of the story here is the healthcare system in the United States. And I think that without understanding some of the basics of that and how it differs from your own experience, both as patients and as young physicians, as medical students, I think it would be impossible for me to tell you what to expect in residency or even why to come to the United States for residency. So today we're going to take what we call in the United States a bird's eye view of the healthcare system here. This will be a talk that is very heavy on numbers. I want you to go back 2 slides, please. This is very heavy on numbers, not a lot of personal anecdotes for this one, but a lot of numbers, something to give you an idea of how we practice medicine here in this country. So this first slide, which I provided at the insistence of Tushar Dialysis, is a short history of me. Most importantly, I've been part of medical care beginning in my first year of medical school for 52 years now. I've spent most of my life in private practice, both in general internal medicine and then following an infectious disease fellowship, both doing primary care and infectious disease consultation. I've been fortunate enough to publish 4 articles in the literature and a poster at a national meeting. Proudest of the article that has my name on it in the New England Journal because of the prestige of the New England Journal. I was one of the physicians at the local community hospital that pushed to begin our own residency program, which is now going full force. I was mentor of the year, physician of the year. I have left that institution because the workload was more than I wanted to do at this time in my life. Presently, I'm on the teaching faculty at Cooper University, which is what we call a tertiary care hospital, meaning when people need super specialty care, they're referred to Cooper. Here in New Jersey, I serve in the infectious disease division, and I attend in infectious diseases there and teach the fellows and the residents. At the invitation of Dr. Dioris, I have joined also this year as the coordinator for United States medical training for his prestigious Astute Academy. And words do not allow me to express how happy I am to be doing this, to have an impact on some of your lives and on medicine in America and continue in that role. So we'll move ahead now to the next slide. And this is the introduction to healthcare in the United States. So our goals in this are, there we go. Tushar, please let me know if something happens and my picture is unclear or there's a problem. So we're going to look at these slides together, folks. So here are our goals for this evening there and this morning here. We want to try to understand the shape of medical care in the United States, a profit-motivated, health-insured, resource-delimited setting. And what I mean by that is when you read in the literature, in the global healthcare literature, they often make a distinction between care in resource-limited areas, which I would consider India to be, and in other areas, which I will call resource-delimited. I want you to understand the basics of medical education in this country. I want to provide you an adequate background to understand the changing shape of medical care, the changing shape of the doctor-patient relationship, the changing shape of residency, and the changing shape of practice of medicine in this country. And I also want to introduce you to the key important role that international medical graduates presently play both in training positions and in practice in the United States. And we'll move to the next slide. Okay, so here's a picture of the United States. Please don't be offended. This is probably hanging in a couple of million third grade classrooms, but this is what we call the United States. Okay, it is a country, the continental United States consists of these 48 states. You can see my pointer moving, I hope, plus the state of Alaska, which occupies the northwest corner of North America, right across the Bering Straits from Siberia, and the island of Hawaii, which is 2,600 miles southwest of the California coast. When I began formally studying India, they talked about the geography, so we can look at some of the highlights of the geography in this country. The span from the east coast to the west coast is just over 3,000 miles, and from the northernmost point to the southernmost point is about 2,000 miles. Like India, we have a variety of geography here. We have a large mountain range called the Rocky Mountains, up to 15,000 feet, certainly not the Himalayas, but we like to think of them as mountains. Many of the tallest ones have snow on the tops all year long. There are separate smaller ranges through California, Oregon, and Washington here. There is a mountain range going down the eastern part from north to south here, where the peaks are as high as 5,000 feet. The entire center of the country here, I don't know why there are two pointers. I don't get that, but my pointer's white here. In the center of the country, this was formerly the bottom of a huge lake. So these are the plains of the country. This is where we grow our food. As you can see, we have thousands of miles of shoreline here, including the Atlantic Ocean, the Gulf of Mexico, which is part of the Atlantic Ocean, the Pacific Ocean here, and the 5 Great Lakes here all have huge coastlines. We have a variety of climates at sea level here, as you do in India. July is the hottest month of the year in this country. Up here in Minnesota, the average temperature in July is about 73 degrees, and down here in Phoenix, that's 94 degrees. Dr. Dioris tells me it was up to something like 109 degrees there. We think Phoenix gets pretty hot. We think Phoenix here gets pretty hot. There's a desert here. There's a desert here. We don't have any tropical rainforests, but we do have rainforests that are non-tropical rainforests by our geologists' definition. We don't have monsoons here. We have sort of rainy seasons, sort of drier seasons, no monsoons. However, we have a fair share of hurricanes coming up this way and lots of tornadoes lately in this time of climate instability. Next slide, please. So here we see a map of India superimposed on a map of the United States to give you an idea of the difference in area. And we have some key numbers that I've assembled for you to look at, which I think are very important. India country, and let me say now that my area of literature expertise is really limited to infectious diseases and woodworking as a hobby. I don't vouch for the absolute accuracy of these numbers. They're from different years sometimes, as they are throughout, but they should give you a pretty good idea of the points I'm trying to make. So India here is a country that's about a third of the size of the United States, with 4 times the population, 1.4 billion versus 332 million people. So if you do the math real quickly, you'll realize that the population density in India is 12 times that of the United States. So you can begin to think of the United States as someplace with more rural areas than India. As you look at cities over 1 million, we have 10 of them, highlighted by New York City at 8 million people. From what I can tell, you have 46 cities of over 1 million, with Mumbai at 18 million. Looking at the gross domestic product or the gross national product, however you like to portray the economy of the country, the United States has the largest economy of the world. We're number 1. India has the 5th largest economy, but quite a bit smaller, 13% the size of the United States economy. When we look at how many dollars per person per population, you can see that for every $100 or 100 rupees or 100 whatever unit of currency per person in the United States, there are $3. So we're talking about the GDP per capita in India being 3% what it is here. If you begin to look at the density of doctors, we can look at how many people there are per doctor. In India, per doctor, there are almost 1,200. In the United States, there are almost 400. So we have a lot more doctors for the population than does India. But the really startling differences between the two countries are in how much money is allotted for healthcare. And I'm one who believes that money tells a lot of stories and it objectifies things. So not a lot of personal anecdotes on this webinar, much more about money and numbers here. So if we look at the percentage of the gross domestic product, India spends about 18% of what the United States does on healthcare. The United States spends the second largest amount of its budget on healthcare in the world. If you look at the healthcare budget per capita, again, India being a much larger country, 4 times as large population-wise, the differences are really startling. So for every $1,000 we spend on a US citizen in healthcare, for every $1,000 or 1,000 rupees, India spends about 6. So already what I want you to see is we're spending a lot more per person on healthcare, and we're going to get into how that happens in action. Let's go to the next slide, please. So again, at the invitation of Dr. Dioris, I'd like to give you an idea of why you might want to think about training doing your residency fellowship in the United States. First of all, there are a huge number of opportunities. We have over 144,000 residency positions in this country. Presently, about a fourth of them are occupied by what we used to call foreign medical graduates, now international medical graduates, IMGs, if you will. In addition to residency, post-residency positions, fellowships, there are fellowships in 91 different specialties in this country, 91. 38 of them are boarded, meaning you can take a test and become board certified rather than just say you completed a fellowship. This breadth of opportunities continues. Besides just the gross numbers, there is a great diversity of opportunity here. Intellectually, we have residencies in 34 different specialties, almost 10,000 first-year positions, PGY, postgraduate year #1 positions in internal medicine in this country, all the way down to the rarest of specialty, that of pediatrics, medical genetics, for which there are 27 positions available in this country each year. In addition to that intellectual breadth of opportunity, there are a huge variety of programs in sizes and locations. We have programs that have a total of 10 internal medicine residents to programs that have over 125 medical residents. We have tertiary care hospitals. Once again, those are hospitals that provide the most special care, that have residencies, down to small rural hospitals that take care of everyone in their community, maybe 150, 200 beds that have residencies. We have programs in large urban areas, New York City, Dallas, Houston, Los Angeles, if you like to live in a big town. We have programs in university-based cities, Ann Arbor with the University of Michigan, Columbus, Ohio, etc. We have programs in rural areas where in cities of 30,000 people. We have programs where the weather is cold, programs where the weather is hot. We have programs in deserts, mountains, and along the shorelines. So it's sort of whatever you like, you can find in this country. Additionally, and perhaps most importantly, this is probably the center of medical research for the world. Over $200 trillion is spent annually for medical research here. 2/3 of that is from change that, please. That's $200 billion. That didn't even sound right to me. About 2/3 of that is from industry sources. So if you're looking for what's on the forefront, what's coming next, that's in the area of research. And most of this research filters its way down through medical schools into residency programs, et cetera. So the opportunities here are I believe, unmatched in the world. Okay, let's go to the next slide, please. So let's talk about medical school in this country. All licensed physicians in the United States have to attend a certified United States or Canadian medical school. We have a certifying agency here as listed below, or a recognized medical school in another country, an international medical school. We here in the United States don't pretend to be smart enough to certify other medical schools. That's a matter of their own locality. Foreign medical schools are recognized, however, but not, as I said, not certified by the ECFMG, the Education Committee for Foreign Medical Graduates. Now, in this country, almost all of the medical schools require completion of either a Bachelor of Arts or Bachelor of Science degree. These always include a core of pre-med courses that include inorganic and organic chemistry, biology, physics, and calculus. Typically, your BA in this country takes 4 years. If you go during the summer, you can complete it in 3 years. For those who are interested in finishing in a greater hurry, there are about 17, it varies from year to year, programs of 6 or 7 years in which you can get a combined Bachelor of Science and MD degree. All students applying to medical school in this country take the MCAT test, the medical college admission test. Admission to medical school is based on your grade point average. A grade point average of 4 is straight A's, B is a 3, C is a 2. On your MCAT scores in your interview, as well as a medical school application, which is now standardized throughout the country. So you apply to each medical school with the same application. That application, very importantly, includes a personal statement, which is going to tell the medical schools why you want to be a doctor or relate some personal experience. Medical schools in this country, I must say, are variably committed at this time to ethnic diversity. Ethnic groups listed in this country include Native Americans, Caucasian, African American, Hispanic, Asian, etc. Medical experience is considered desirable by most admission committees at this time. And if you get nothing else from this first set of slides, understand that these qualities that are listed on the bottom line are becoming increasingly important as medical schools and residencies look at their many candidates. They want candidates to demonstrate leadership ability to work in a team, and good communication skills. These are all being emphasized much more than they ever were. There is also a movement now to change the pre-medical school experience to not include things like calculus, but include statistics, include more communication skills, etc. But that's beyond the scope of this talk today. Next slide, please. Okay, so one thing you're going to encounter both in the literature as you read articles, and if you do choose to come to this country, is you're going to find doctors with the initials DO after their names and doctors with the initials MD. These represent two groups of medical schools which are getting closer and closer together. There are 154 schools that offer an MD medical doctor or allopathic degree. There are 38 schools that offer a doctor of osteopathy or an osteopathic degree. Admissions to these two schools are parallel, but frankly, DO schools continue to be less competitive as measured by the average grade, by the mean grade point average, etc. DO schools are affiliated with less prestigious private undergraduate universities and university hospitals. Curricula are identical, but osteopathic schools continue to teach massage and skeletal manipulation, which has been a core element in osteopathic medical education from the beginning and continues today. Most of the DOs that I know sort of disregard this, which I think is terrible because just a personal viewpoint, I think you have to know in this world what you're good at and what you're not good at. One of the things that prescription medications and MDs are not good at is treating musculoskeletal conditions and musculoskeletal pain. I think that massage and skeletal manipulation for me has worked very well in that regard. But enough of my little anecdotes and back onto the business at hand. In 2021, things changed radically in this country. There used to be separate DO programs and allopathic programs. Essentially, the DO programs were taken over by the allopathic programs. The ACGME, the Accreditation Committee for Graduate Medical Education, now supervises all training. So there is no longer a distinction in training. What we're really seeing is that there was a huge distinction in 1915, and now 107 years later, there's not a whole lot of distinction. I will say that if you look at how hard it is for a DO to get into a training program, they don't compete quite as well as MDs do in getting the residencies that they designate for themselves. Okay, next slide, please. Okay, so medical school in this country is very selective, very competitive. I will apologize again to you. I'm not that familiar with the Indian system. That's going to change, I hope, in the fall, when I will be traveling to India, but I'll give you a picture of what medical school is like in the United States. So we'll start out with how selective it is. If you look at the most highly rated United States medical schools, you will see about 40 applicants for every position that is filled. It is lowest, and once again, one of the themes of this is going to be that money, finances determine a lot of how things go on. So the most competitive medical schools right now are New York University and Kaiser Permanente. Their admission rates of 1.1% and 0.6% are listed in parentheses. These are tuition-free schools. The mean grade point average, again, 4 is all A's. The mean grade point average at the most competitive schools is 3.93. A perfect score in the MCAT these days is 524. The mean score is 522 at the most competitive of the schools. Looking at all of the medical schools, the admission rate's about 40%, about 2.5 applicants for every spot. However, the theme in medical education, one of the themes is that if you're accepted to a medical school, they want you to graduate. So they will do everything they can to help you along the way, and graduation rates are above 90% in United States medical schools. Next slide. Okay, medical school in the United States is expensive. So this is based on a report from 2020. Public medical schools, that is to say state medical schools, for 4 years are going to cost about $62,500 per year. That's converted over to rupees in parentheses there. Private medical schools, which predominate, are more like $82,500 per year these days. That does not include living expenses. That is just tuition, books, microscope, etc. So we see that if you're an in-state student, so if you live in Michigan and you apply to the University of Michigan or to Michigan State or to the medical school in Detroit in the Henry Ford system, your tuition is going to be lower than if you're a New York citizen going to Michigan to go to medical school. With this expense, many private universities offer large need-based scholarship, and especially in the face of having tuition-free medical schools, many of them will tell you that anyone who qualifies, they will make sure that you can get through financially. However, about 75% of medical school graduates graduate with educational debt, and the average debt is about $220,000, which is a lot of debt. And most of the people who graduate with that debt are going to carry that through residency into practice. And I believe, just my own personal comment here, is that that guides them very much in their choice of practice in terms of looking for the types of practices that are going to provide them with the highest income so they can pay off those debts. Interestingly enough, and my personal comments in these webinars are going to be mostly in red so you can spot them easily. Like universities in this country, how good your medical school is has nothing to do with what the tuition is. It's one of the few areas, at least in this country, in which what you pay has very little to do with the quality of the product. Same is true for undergraduate schools as for medical schools. Let's move to the next slide, please. Okay, so let's look at the curriculum in medical school here. First 2 years are spent basic sciences, lectures in small groups, including some laboratory work and some microscopy work. Subjects include what you would expect: anatomy, physiology, biochemistry. Many medical schools now have taken to a system-based approach where they'll teach cardiovascular system, go over the anatomy, the physiology, the biochemistry, the pharmacology of that system, and then move on to a different system. There's no demonstration yet of which way of teaching medicine is best, and I'm sure it would depend on what you use as your endpoint, as your parameter for success. Medical schools in those first 2 years also include an introduction to patient care, history-taking, physical examination. Lately, which is to say in the last 10 to 15 years, there is an increasing emphasis on cultural-based learning, approaching your patient within their own cultures, training in empathy, clinical problem solving, and some formal coursework to look at how healthcare has been inequitable in this country, basically along racial and income lines of thought. Last 2 years are spent on clinical rotations. Primarily, clinical rotations are done in the hospital. Most students spend their entire third year in the hospital and most of their fourth year in the hospital. This begins for me what is a slant and emphasis on inpatient care in this country, which has probably resulted in some of the problems we have in delivering care in this country. But the thought I want you to walk away with is that your clinical experience in medical school in this country is mostly inpatient, which is to say the hospitalized patient. All right, let's move to the next slide, please. Okay, so these students come out of medical school and they're looking at residencies, they're looking at what they want to do for a living, and many of them are motivated by the amount of debt they have to pay off. So here we see in green and red, green is the color of money in this country, in the United States. Red is the color that's used by my accountant when I owe money. So that's the debit column. So over on the left, you can see the highest earning specialists led by the plastic surgeons who earn over $500,000 a year. These are converted, the top earner and lowest earner converted to rupees down at the bottom of the slide. If you're more comfortable with that currency, as I expect you might be. At any rate, plastic surgeons make the most, pediatricians make the least. I will say these numbers come from surveys of physicians, so I'm not sure of their accuracy. I think if you're making less money, you probably might not want to tell anybody. Maybe you want to tell somebody more. Nonetheless, these are the best numbers that we have. You will notice another great slant in American medicine, which is that procedural-based specialties, surgical specialties, gastroenterology with endoscopies, colonoscopies, cardiology with echocardiograms, cardiac catheterizations, cardioversions, etc. you will see that everything, with the possible exception of dermatology, that are the highest earners are procedurally based specialists. So what happened in this country is, prior to World War II, ending in 1945, there was really virtually no such thing as health insurance. With our soldiers returning from the wars and everybody trying to get a post-war economy together, and the rise of surgery as a safe procedure, medical care became much more expensive than it had been. And so private health insurances started and became popular and nearly universal until about 1960, 1962, when the United States government decided that its increasingly aged population, people over 65, who were earning an income on what we call Social Security, needed more money for medical care. So Medicare was founded, and we'll take a little closer look at insurances then. But the point here is that insurances pay the most for procedures, and that's what's reflected in incomes there. You can see the lowest earnings over there, and we're going to look at where international medical graduates fall on this at the end of this presentation. In parentheses there, you'll see growth rate or decrease in income rate, but that's over a year's time. That's a pretty stable number, and again, probably within the error of this of the accuracy here. Let's move to the next slide, please. So we started out with medical school saying that the introduction of medical students to medicine is mostly inpatient. So let's take a look at inpatient versus outpatient care in the United States. So we have almost 36,000 hospital stays, about 164,000 days in the hospital in this country, which costs us, at the very least, a little over $417 billion. So inpatient care in this country is well over 4 times, 5 times the entire healthcare budget in India. Outpatient care, not including dental care, eyeglasses, physical therapy visits, compared to 164,000 hospital days, there are 860 million visits to physicians in this country. And the ratio of these visits, so there are more than 5,000 visits to doctors than days spent in the hospital. But the money is spent more on inpatient care, as we'll continue to see. And the reason I keep emphasizing this is a point of criticism in American healthcare when we look later on at what our return on investment has been here. Let's go to the next slide, please. Okay, so this is a pie chart showing where we spend our money. So we can see that we're spending 31% of this $3.8 billion, this $3.8 trillion. We're spending 31% of it on hospital care, despite the fact that there are 5,000 visits. That is probably an underestimate, because physician services include hospital physician services, which are fairly expensive because they involve surgeries, etc. We have something in this country called nursing homes. I don't know if they have them in India. My impression is not. So many elderly people who no longer can care for themselves are not cared for by family members, but in nursing homes. That's about 5% of the budget. Also, nursing homes serve as rehabilitation facilities following hospitalization in an attempt to prevent readmission to the hospital. We spend lots of money, almost 10% of our budget here on drugs. I will say that medications in this country are largely prescription. I don't know what that's like in India. Right now, you can get proton pump inhibitors, your omeprazoles, etc., over the counter. But hypertension medicine, diabetes medicine, cholesterol medicine, which a lot of people take, they're not over the counter. They're all prescription. One of the key things I want you to come away from this slide with, if you want to understand where medical care is going in this country, is that we spend 10% of our healthcare budget, and well over, somewhere between 5 and 10 times what's spent on healthcare in India. we spend 10% of that on people in the last year of their lives. And there's been lots of changes suggested for healthcare in this country to make that a less extreme number, less high number. Cancer care takes up $150 billion alone. Prescription drugs is above. We spend $7.7 billion on opioids in this country for pain. And just over that at $9 billion, that's back in 2013 on chemotherapy. All right, let's move ahead to the next slide, please. Okay, let's take a look at how and where physicians practice in this country. So basically all emergency rooms of size employ physicians trained, boarded, or board eligible in emergency medicine. There are 42,000 of them, roughly speaking. People that could be involved in primary care, which would be pediatricians, geriatricians, internal medicine doctors, and family doctors, comprise only 34% of the physician force in this country. And that's probably an overestimate, because about 44,000 of these internal medicine or family medicine doctors are hospitalists. That is to say, they take care of patients in the hospital. They provide no services outside the hospital. And conversely, outpatient doctors often these days don't provide any care in the hospital. We have 12% of our doctors are in surgical specialties. 103,000 of our doctors are in internal medicine specialties other than geriatrics, meaning they're not doing primary care. And we'll have lots of radiologists and radiation oncologists. Okay, in this, just for the record, I took an AAMC report, the American Academy of Medical Care, from 2020, and took only physicians involved in patient care and teaching, not administrative positions. Okay, let's move to the next slide, please. So let's look at healthcare by looking at how specialized it is in this country. And I'm going to give you a couple of examples. So out of all those general surgery residents, more than 3 out of 4 of them are going to pursue fellowship training. That means they're going to do some of what's still called general surgery, but they're going to have some additional initials after their names. So general surgical specialties include breast surgery, burn surgery, surgical critical care, transplant surgery. Many of these are not boarded specialties, meaning you don't take a test to say you're board certified, but some of them are. Clearly cardiothoracic, vascular, plastic surgery are all boarded, etc. Okay, let's move to the next slide. Another good example is all of our orthopedic surgeons. You'll recall that orthopedic surgeons are way high in the income category in this country. So greater than 90%, okay, more than 1 out of every 10 graduating orthopedic surgeons. My son is an orthopedic trauma surgeon. And when I asked him, how many orthopedic surgeons, how many orthopedic residents are going for specialties? He said, oh, almost everybody. So there are the 11 fellowships offered to orthopedic surgeons. None of them are boarded, but all of them are important. My son, as I said, is an orthopedic trauma surgeon. He did a 1-year fellowship in trauma surgery. Fewer than 1 of 6 orthopedic surgeons in practice today identify themselves as general orthopedic surgeons. Okay, next slide, please. Okay, let's look at, since we've identified surgeons as the highest paid and where we're spending a lot of money, let's take a look at some of the high volume elective surgeries, and we're going to look at procedures per year. Part of me wants to apologize for all of these numbers, but I think numbers are great objectifiers of what's going on. And so this is a highly number-oriented presentation. I hope everybody's comfortable with that. Okay, if we look at cataract surgery, which is in fact elective in this country because the criteria for getting your cataracts operated on in the United States is that you've had a decrement in vision. So if you were 20/20 and now you're 20/40 and you have cataracts, you're going to have them removed. We spend $14 billion a year on cataract surgery. We do over 1 million total knee replacements and total hip replacements. So as you can figure out by the number of years I've spent in the medical care system, you can estimate my age. I can tell you there is no activity I go to, not a party, not a pickleball game, not a golf tournament, nothing, that there aren't one or two people there who've had total joint replacements. Breast augmentation. We do almost 200,000 of them. Breast augmentations are not paid for by insurance. Bariatric surgery, that is to say surgery for morbid obesity, is another 250,000 procedures a year. It is often said, it was said to me for the first time by one of my dearest friends, who's an Indian physician and a close friend of Dr. Dioris as well, who practices oncology. He said to me, this is the only country, meaning the United States, where the poor people are fat. I don't know about that, but that's what he told me. So we do 250,000 procedures, bariatric procedures a year at a cost of $4.5 billion. We spend $34 billion a year on physical therapy. I would also add, and this is a personal comment, that if you look in the literature at what physical therapy is good for, does physical therapy work? What does it accomplish? You will find that it is very hard to demonstrate that physical therapy for most things accomplishes very much other than post-operative physical therapy. Yet we spend all this money. This is mostly what we call defensive medicine, because no orthopedic surgeon is going to do a major procedure on you without you having physical therapy. So in case you sue the doctor for malpractice, he can show that he did everything, or she did everything she could, short of surgery first. These 5 items, I have them listed as representing 83% of the Indian healthcare budget. Again, the Indian healthcare budget has been very elusive to me to come up with. So we'll call it 83%, but it's anywhere between 50 and 110%, I would say. Let's go to the next slide, please. As I continue to bombard you with numbers, healthcare in America is high tech, high tech. In this country, we have 13,345 MRI machines. Shortly after MRIs were developed, I can remember a time when in Vineland, which is a town of 60,000 people, we had 3 MRI machines, and there were 3 MRI machines at the same time in the city of London, a city of 8 million people. There are 600 MRI machines or so, as far as I can tell, in India. Average fee for an MRI in this country is $1,345. I think it's somewhere around $200 in India. PET scanners in this country, average fee is $5,800 or so for a PET scan, somewhere between $200 and $350 in India. As far as I can tell, there are fewer than 10 of those in India. Here we have 2,100. Proton therapy is a form of radiation therapy for cancer, largely unproven to be superior to routine radiation therapy, but felt, however, maybe to have less morbidity. There are 3 proton therapy machines in India, as far as I can tell. There are 34 in the United States, and I can tell you that 34 is increasing rapidly. In 2017, now 5 years ago, we did almost 700,000 surgeries robotically. We do 600,000 cardiac catheterizations for acute myocardial infarction alone in this country. Solid organ transplants, not including small bowel, pancreas, hand, and face, $19.2 billion a year. Bone marrow transplants, $5 billion a year. About 30% for those transplants of the entire Indian healthcare budget. And that's just doing the transplant. That doesn't include post-transplant care other than immediate post-transplant care. We can see one of my favorite examples, although it's hard to pin down, is ECMO, which is extracorporeal membrane oxygenation, which is sort of dialysis for the lungs. If your lungs aren't working well enough to either get rid of CO2 or more commonly to get enough oxygen into you, we have a machine that will do that. In the first 15 months of the COVID epidemic, at a cost of $5,000 to $10,000 per day. Okay. We had 8,000 patients in the United States on ECMO compared to 208 in the continent of Asia. Okay, we spent somewhere between $4 and $22 billion on a procedure that was associated with an in-hospital, that's in-hospital mortality of 50% at best. Okay, let's move to the next slide. Okay, let's take a look quickly at cardiac care. Once again, high tech, over 1 million cardiac catheterizations, over 600,000 stents, 500,000 open heart procedures, TAVRs, which are catheter-introduced aortic valve replacements, 700 a year. I'm sure that's over 1,000 now. Let's remember those procedures are done almost exclusively in people in their 80s. 2D echoes, 31 million a year, and I think that's an underestimate. I can't tell you what percentage of patients hospitalized in this country have an echo, but if you call a cardiologist to see them, they're going to have an echocardiogram done. Let's move to the next slide, please. Okay, so I've tried to give you in very broad strokes a picture of how much of that green stuff, that money, is spent on healthcare in the United States. And so the critics of healthcare in this country point to certain things. What are we expecting from our healthcare? What kind of outcomes can we show? Looking at countries that are members of the Organization for Economic Cooperation and Development, and you can see them. So we're talking about North America, selected countries in South America, Central America, almost all of Western Europe here, and Turkey. Out of these 35 countries, the life expectancy in the United States is number 28 of those 35. However, I would hasten to add, proud of being an American, of course, is if you reach age 50, our rank in life expectancy is probably closer to 5. All of this reflecting that we have a high pregnancy mortality and infant mortality. Defenders of the healthcare system will say this is related to social inequities, poverty, etc. Critics of healthcare will tell you that's what healthcare is about, is serving the population. Next slide, please. So let's look at pregnancy care and how well we're doing for all this money we're spending. Pregnant women in the United States are virtually entirely delivered in the hospital setting. Few women choose to deliver at home. I don't know how that is in India. I suspect it's rather different. So in this country, the standard is sometime in your first trimester, you should begin pregnancy care. However, only 77%, 1 out of every 4 women, roughly speaking, begin later than that. And 2% of them get no prenatal care. They show up at the hospital. Having had no prenatal care, no HIV screening, no Hep B screening, no Group B strep screening, etc. Okay, another result of our health care is in the United States, all children are to receive these 7 vaccines on a scheduled basis. About a third of them don't complete those vaccines appropriately. Let's go to the next slide. Okay, I want you to turn your attention to the right side of this slide, which is patients on dialysis in this country at a cost of $90,000 per year. Our total cost is $87 billion, well over expenditures on healthcare in India on end-stage renal disease alone. So we spend a lot of money on end-stage renal disease, $87 billion. Okay, so what causes end-stage renal disease in the United States? Well, we have a few people who had glomerulonephritis, some with congenital difficulties, some with trauma. But the great part of those patients develop end-stage renal disease by poorly controlled diabetes and by hypertension. When we look across the population at how well we're controlling hypertension, using a very liberal 140/90 right now, which the literature might be telling us that we should be reducing it lower than that. We have 24% of our hypertension patients well controlled, 30% of our diabetes well controlled. So imagine, if you will, if we controlled 50% of those hypertensives and 3/4 of those diabetics well. how much savings we have on the right box, end-stage renal disease. Next slide, please. Okay, so we know there's a lot of money being spent on care. Where is this money coming from? So America is, largely speaking, an insured country. We'll look at what happens to the uninsured, but at any given time, about 90% of Americans have some form of health insurance. What kind of health insurance you have is going to determine to a great extent what kind of care you are going to get. So as I said earlier, in the 1960s, we began with Medicare, which was something for people over 65 years of age. It's paid for through Social Security funds. It is the only form of federal government insurance other than patients attending veterans hospitals and federal government employees. All Americans over 65 years of age get Medicare. Americans who are disabled, all dialysis patients get Medicare. Okay, there are separate parts paid for hospital care, outpatient care, prescription medications. Part of that is paid by patients. I will tell you, my wife and I are paying about $12,000 a year for Medicare. Okay, Medicaid, on the other hand, is there for people of very low income or no income. This is funded by corporate taxes and excise taxes. Excise taxes are things like cigarette taxes, gasoline taxes. Medicaid is administered by the states under federal supervision. There are huge differences from state to state in coverage by Medicare. There is no cost to the patients. However, there is a very low reimbursement for Medicaid patients. So many physicians do not accept Medicaid patients for primary care. And so they go uncared for or cared for in crowded clinics that can't provide the kind of care that other doctors can. There's another form of public insurance, which has been with us for about 10 years, that's referred to as Obamacare. Let me move to the bottom. Private insurance. Private insurance would cost a family of four these days $16,000, $17,000. So it is unaffordable to many families. So private health insurance is paid largely through employers. Most workers pay part of their own private health insurance. That varies greatly. So for those who can't get private insurance through their jobs, they're self-employed, they're employed by small employers, 4 employees or less, whatever. They get insurance through private insurance companies, but they are pooled together. And we'll take a look more at how this $3 trillion healthcare is paid for in the next slide, please. You can see that this is private insurance is paying for much of hospital care, Medicare, Medicaid. What's really important here is over on the left, how little out-of-pocket money is spent on hospital care. When you come down to physician clinical services that are including a lot of outpatient care, more out-of-pocket money, but mostly insurance, as you can see my pointer going from dark brown, dark green, light green is going to pay for this. For prescription drugs, we have increasing amounts of out-of-pocket cost, decreasing amounts of Medicare, Medicaid. Medicaid pays 100% of all prescriptions. Medicare pays for a lot of prescriptions, but there's a lot of copay left, and it's important to remember that depending on your income level at age 65, you are paying some of your own Medicare expense. Now we go to these nursing homes. In nursing homes, you can see there's very little Medicare expense except for rehabilitation after hospital. Medicaid pays for nursing homes, and out-of-pocket costs in nursing homes are high. And then we come down to dental care, ophthalmologic care, etc. Okay, let's move to the next slide, please. Okay, so you can see again on this slide, heavy participation of insurance for prescription drugs, physician and clinical services, hospital care. Medicare is not going to pay for nursing care or dental care, and significant outpatient expenses for nursing care, dental services, or other medical products. The question, if you're a healthcare economist, that you want to ask yourself about, and this is a subject of huge debate in this country, is whether high ticket, high cost items are insured because they're expensive, or they're expensive because insurance is paying for them. A personal example I can give you is someone I know was told that his radiation therapy for cancer would cost $175,000 to complete. He did not have insurance that covered that. He negotiated that down to a $60,000 out-of-pocket charge. So whether healthcare expenses are insured because they're expensive, or they're expensive because they're insured, that's a very interesting question. Next slide, please. Okay, I'm going to skip this one. Let's keep this slide up. I'm just going to turn your attention to this part of it. So at any given time, 9% of the American population is uninsured. Adding the Medicaid population, that's a pretty substantial number. In most states, these patients cannot be refused emergency care or hospitalization. In some states, private hospitals don't have to take these patients, so they're transferred over to city-owned hospitals or state-owned hospitals for care, which is to say that virtually no one in this country can't get acute care and can't get follow-up chemotherapy and everything else, even though they can't pay for it. However, what is really impossible to achieve so far in this country is adequate preventive care or chronic disease care for these uninsured patients. And the problem then is, if you're not taking care of things on a preventive or a chronic care basis, you're going to wind up in a very expensive situation, needing surgery or dialysis or transplant, etc. So I would turn your attention to the lower part here, which is to say Americans are really divided at this time on whether or not good healthcare is a right or it's a privilege. If it's a right, then we need to modify the present system, single party payer. But there's a lot of conflict even among those who think that healthcare is a right that everybody should have in this very wealthy country. And so far, because payment is so scattered between private insurance companies, which are making a fortune selling insurance, Medicare, Medicaid, out of pocket, there is no consistent economic force that is forcing change. So change is coming very slowly in healthcare in this country. Next slide, please. Okay, this is a summary slide. For the interest of time, I'm going to skip this slide and we'll move to the next slide. Okay, let's take a look at what international medical graduates are doing in this country. So about 25% of practicing physicians in the United States are international medical graduates. The largest component of these are from India. They are said to represent 25% of the international medical graduates. I'm going to tell you this is the best number I could find, but I have no confidence in this number. I think it's a greater number than that, particularly if you exclude United States citizens who have their medical education out of this country. Okay, this percentage is stable, but the total number is over 250,000 international medical graduates. International medical graduates are formally recognized by the American Medical Association as they've played a huge role in care in underserved communities, which include both poor urban areas and rural areas where the population is very spread out. Okay, let's move to the next slide, please. Oh, this one got messed up. Oh, let me see. Move to the next slide and see if it came out better. I don't know what happened. Yeah, okay. Let's move back to the previous slide. So let's see what international medical graduates are doing in this country. So we're going to say they're 25%. I don't know what happened to this slide. So this is what they're doing. In what fields are they overrepresented, which is to say many more than 25%, and where are they underrepresented? So if you look at where they're underrepresented, and again, I apologize, this was not my original slide. you can see the areas they're underrepresented are the areas that, largely speaking, are making the most money. And this will be illustrated better in the next slide. Where they're overrepresented, by and large, and it's hard to tell here because we're missing a lot of them, are the less economically rewarding specialties. Let's go to the next slide. So the next slide tells you where international medical residents who are training in this country, what are they training in? Once again, we've gone to the green is the color of money and red is the color of owing money. And you can see where IMGs are overrepresented, mostly are in specialties that aren't making the most money. There are a couple that are in cardiology in particular. Where they are underrepresented, you can see that 1, 2, 5, 6 out of 10 of those areas are the most money making specialties. Okay, let's move to the next slide. All right, I'm going to end the presentation here and open it up to any questions. So fire away. Let's take the slides off the screen, please.
Yeah, so thank you very much, Dr. Kaufman. Really, this was a great presentation, lot of statistics, but all very, very useful in understanding the American education system. And those of the students who are not able to really correlate the dollar value to rupee value, even though some of the areas which are not that greatly represented or maybe in the red part of it, if you see the salary structures is around $2,250,000 to a great areas which we were talking about, surgical and even oncology, and Indian rupees maybe around 2 crores to the 4 crores rupees per year if you translate into Indian crores. So, and that is so much of spending into the medical system in United States. Those figures were really uncomparable to India. So these numbers, if you go through that, it makes a tremendous sense as such to really look into a great country. So I will just check up now the questions, and any of the questions, you can start typing the questions into this part of it. So I will take only the questions which is relevant to today's topic. I don't want to currently take very, very off-track questions which are not today the relevant part of it. So one question was there, sir, I'm a first year physiotherapy student. What is the scope for physiotherapy in United States? I think this is also today, maybe Dr. Kaufman, you'd like to answer on physiotherapy, physical therapy questions in the United States.
So my understanding is that to train to be a physical therapist is somewhere between 4 and 7 years in this country. There are certified physical therapy programs, and completing them gets you certification in physical therapy. The really critical matter, and in this country, it may not always be about money, but money really tells a big story. So the critical question in this country is whether physical therapists can own their own physical therapy practices and do physical therapy, which is paid for by insurances, again, paid for by insurances, not on a prescription from a doctor. And thus far, most insurance companies have insisted on prescription from a doctor in most states, but this is an area of considerable conflict, and physical therapists obviously want to be able to run their own businesses, etc., and determine who needs physical therapy, etc. But that is a battle at this time. I hope that answers. The scope of physical therapy is huge, going everywhere from gee, I have some back pain, I'm 70 years old, I tell my doctor about it, and he says, go to the physical therapist. They'll show you how to stretch and to strengthen your back muscles. Typically, that's going to get 9 physical therapy visits so they can supervise you, elderly people with gait instability, and that goes all the way down to I'm going to have my knee replaced, but I've been limping around. I have an office job. My legs aren't very strong. So I'm going to go to physical therapy to get my legs strengthened. As is typical in this country, we assign a highly trained, again, a 7-year post-high school graduate to show me how to do exercises. This is an editorial comment that I can do at home, but we're going to pay for me to go there so that person can do the exercises with me and supervise me. Each person can judge for himself whether that's a worthwhile enterprise or not.
Yeah.
Okay.
Yeah, there is another question. Okay, you had mentioned the earnings for various specialties. So what figures it varies from around $250,000 to even $500,000 a year. Are these for the as a entry level, somebody who just passes the residency, or these are the figures for after some years of experience? What is the average way?
That's a great question. That's a great question. So let's turn to the area where I'm always most comfortable, which is how did you gather your data? So this data is gathered by several different groups. Some of the colleges will do, in other words, the American College of Plastic Surgery, which administers the board exam, is going to do a survey of its members. It's going to say, what did you make last year? Some of them are done by informational services like doximity, social services. My own association, the Infectious Disease Society of America, does a survey of infectious disease doctors. So these numbers well reflect the breadth. They're going to be whoever answers the question. So there is no emphasis on experience. What I think the questioner is getting to is, gee whiz, what happens in this country? Do you make a lot more money when you've been in practice for 5 or 6 years than when you first start? And the answer to that is kind of twofold. So if you're working for a hospital system, okay, which many people are, increasing numbers of United States physicians are working for an institution. The salary to start is the same as the salary if you've been there for 5 years. There's not much to be gained by experience. If you're in a purely private practice, you've probably been smart enough to pick an area where there's a need. But if you're a plastic surgeon, it's going to take you a few years, maybe 2 or 3, to build up your reputation. If you're working for an already established private practitioner, they're going to pay you commensurate with how hard it is for them to hire somebody. So if they're in an area where that's less attractive to people, they're going to pay more. Generally, after a couple of years, you're going to become a partner and share in the profits of that practice. So what I would say to the questioner is, don't have this image that 5 years into it, you make a whole lot more than 1 year into it, or 10 years more than 5 years. You're going to reach your plateau rather quickly. I hope that answers that question.
Yeah, definitely. There are certain questions which are coming, which is repetitive. And I would like to make some this clarification into that. In United States, the doctor of medicine or doctor of osteopathy, the MD and DO programs are equivalent to MBBS in India. These are not a post-graduation. Residency, the name of the post-graduation is a residency program. So do not confuse the MD program with the residency program. Residency is you are going into the specialization part of it. Like in India, we call the specialization as MD, but in United States, it is still After the pre-medical of 4 years, you go into the 4 years of Doctor of Medicine, followed by then the residency program where you are going for the specialization. So whatever fees and all being told, that is for the MD and DO programs, what we have put it into that. The residency programs, most of the residency program, there are no fees. So money part doesn't come into the residency part of it. So there are slightly, some students got confused into that, and they were asking for the specializations and the fees questions. So I'm just clubbing all the questions and just making this the clarification into the systems.
Yeah, I'm sorry. I'm sorry if that was not clear. I apologize.
Yeah, no, I was expecting. So another question which is there, we have heard that getting into the admissions into the clinical or surgical branches is slightly difficult, more difficult than any other specializations into the residency. So what it makes to really, I want to take the admission, what it makes to really make the profiling part of it. Even though we will be covering this question in the next session, but maybe in the briefly, if you, doctor, you can just.
Dr. Dioris, I'm not quite sure what you're asking.
Yeah, they say certain, like we have the residency specializations, like internal medicine and even surgical, even orthopedic surgery and all. Some of the clinical admissions part of it in those specializations are more difficult than into other specialties. So the students definitely needs to have a better profiling for that.
Yeah. So I guess the question comes down to, in a personal level, I'm an Indian medical student. I'm interested in becoming an orthopedic surgeon. These programs are very competitive. And as you point out, we're going to be looking at that through what's called the match program. How hard is it to get these training positions? Where we're going to take a more in-depth look at where international medical graduates have traditionally been. But here we have an Indian student who graduates medical school and he wants to be an orthopedic surgeon. So what is a possible path to that? Well, the first thing I would say is, at the end of the day, in the United States, when you hang up your shingle, as we say, when you hang up your sign, when the sign goes up outside your office that says Dr. blank blank, orthopedic surgeon, okay, everybody's equal. Okay, so you're all striving for a spot, but when you get that spot, when you finish the program, you are equal. So whether you did your orthopedic surgery at Inspira Hospital, where they have 12 orthopedic residents, or Massachusetts General Hospital, if you are going out into private practice, once you get that job, everybody's the same. So we'll start there. What I would say to the Indian medical student interested, for example, in being an orthopedic surgeon, a urologist, some of the really competitive things is that you're probably going to have to spend some time in this country before residency becoming associated with the medical care system where they can get to know who you are. I will say you're going to need to have excellent exam scores. Without them, I think it's going to be very difficult. You may be well served to do an internship in what's called a traditional rotating internship or a general surgical internship, to spend 1 year in a healthcare system that has an orthopedic residency, proving your worth. So you're no longer an anonymous Indian medical student who wants to be an orthopedic surgeon. You're someone they know who has communicated well with their patients, worked well in the team, done a fine job technically, and proven yourself, in which case, now if you're an orthopedic surgery program, you have a known entity. You have someone you know is going to turn out to be a good orthopedic surgeon, and that person will move up on your list. And that, I think, is the formula.
I think that sums up, because most of the other questions are the similar pattern which we have already covered. But surely I will ensure that if any of the questions which are there, those who have participant here, I will write a separate email to that clarifying those questions which was not part of the today's session. I think with this, I would definitely like to thank Dr. David Kaufman for giving such a wonderful insight into the American system. And it's a great country, great education, and lots to learn. If you are a knowledge centric, you want to really learn and want to do something good for the society, this is the place where you should come. Where you settle in the world is different part, but being a great doctor is most critical part of it. And learning part of it, what is latest happening across the world, learning the latest, and getting insight into that and serving to your own country, that is going to be the most critical. And medical profession is one of the most noble profession. You save the life. I always really appreciate, and we have seen during the last 2 years of really a COVID era also, how every medical professional has worked overboard to really do. It's a really great. Thank you very much, Dr. Kaufman. It's my privilege, and we are very, very happy that the student got such a great, even I learned a lot from this webinars. I was not knowing many of the numbers, and this is great. We will be publishing shortly the complete schedule on different topics. We want to get as much depth into even the residency admissions, even the research part of it, the profile building activity. And I'll be very, very happy. Dr. Kaufman will be working one-to-one with many students who would like to work with us, and he will be mentoring those students. He will be taking care of preparing from starting from CV, how to build up the things. Really great guidance in terms of the research. So you can see the Dr. David Kaufman's really association at a longer stage in building your career. It is up to you how great you take the advantage of Dr. Kaufman is one of the best doctors in the area, and I think he with his vast experience, we are very, very fortunate to have him in the thing. So thank you very much, Dr. Kaufman, and thanks all the students for attending today's session.
Well, thanks again to all of you, and I look forward to speaking to you and perhaps some of your friends at a later time, and then meeting you personally. This will be my honor and a great privilege for me. So you all have a wonderful evening, and I'm going to go have myself a good day.
Thank you very much. Have a good day, Dr. Okay.
I shall.
Thank you. Thank you.
Bye now.
Okay, I'll just close the webinar. Thank you very much.